So, the rotator cuff. We covered this on Friday, and I don't understand this very well, but I'm going to give the best brief overview. We have the slides from 11 to 18 today, and so here we go. The rotator cuff. Muscles originate on the scapula and insert on the head of the humerus. They stabilize the humeral head, and they prevent translation of the humerus and allow for an increased force from the deltoids during abduction. The increased risk of injury with repetitive overhead movements. So we'd see this in like a CrossFit type person. And then we moved into talking about the muscles around the shoulder itself. So above, at the superior most on the screen, we have the superior spinatus and then the inferior spinatus, both of which are innervated by the suprascapular nerve. The superior spinatus does the abduction, and it's prone to damage when those arms are up high over the head, right? And it's the most commonly damaged muscle. We also have on the inferior superior side the teres minor, and it's innervated by the axillary nerve. And here we can see the axillary nerve coming right out. You know what? I probably can highlight stuff. Here's the axillary nerve coming right out. Yeah, that's cool. And so let's talk about a little bit more about what we talked about on the tendons. So the coracoid process is coming out there, and then we have the acromion there. And what we talked about and tested around in class was that this tendon, I'm trying to find the name of the tendon because I've forgotten it. It's the, yes, the supraspinatus. So it abducts, but it can slide right out of the joint right there immediately. And when that happens, it's super painful. And and commonly it's diagnosed that you have a shoulder injury, like something's wrong up here, but that's not the case. It's actually that tendon has come out and slid over the I gotta zoom in a little bit, this part of the groove, right? And so you can rotate the arm, I want to say back, so anatomical position, you're going to rotate the hand over and move it back and pull that arm back, and it'll actually cause this to pop over. Well, let me do that again. It'll actually cause this to pop back in to the groove right there. And that's the goal, is to pop it back into the groove. Now I know I'm talking, this is supposed to be, it's recorded audio. If you want to see the video, you'll have to get the video. Okay, let's move on, because that's about all I understand at that point. Then we talked about the shoulder, and we have the only anatomical joint between the upper extremity and the axial skeleton happening where? Right at that sternoclavicular joint right there. Sternoclavicular joint. So that's definitely a test quiz worthy question. I'm going to mark that. The shoulder, in lay terms, it typically is made up of the scapula and the humerus, and the shoulder girdle is made up of the clavicle and the scapula. So the labrum increases the depth of the glenohumeral joint. The labrum increases the depth. That's a big deal. I should mark that as a quiz noteworthy question. Then we had the acroclavicular joint, acromial clavicular joint, also known as the AC joint. The AC ligament we talked about, the articular disc sometimes present, and then the coracoid ligament. And I can't remember where that is, so I'll have to look that up later. We talked about the suprascapular notch. That's the notch that's highlighted right there on the screen. It's the notch at the superiormost side of the scapula. And what runs through there? A nerve. What nerve? I don't remember. Look that up. So what happens is there's a fibrous ligament that goes over the top of that suprascapular notch, and it can harden or ossify, and then the notch becomes a foramen. It's a hole. And this happens commonly in volleyball players, and it affects the nerve. And so they have pain from that. And I don't know what nerve that is, so we need to find that out. The long head of the bicep tendon can slip out and result in pain. We talked about that, the long head of the bicep tendon. And then let's continue on. The muscles of the arm. Probably going to have to watch some of the video because I didn't catch all of this. What I do know is 3 muscles attach at the coracoid process, and we want to name those muscles. There's breakdown into little bits of information. We need to focus on that because there's so much information in this. The anterior compartment of the muscles of the arm, the main action or the flexion of the forearm. The nerve is the musculocutaneous nerve, and the biceps brachii, the long head and the short head, and then brachialis and corabrachialis. So we have those 4 muscles with biceps brachii and the long head and the short head, and the nerve that innervates the whole thing is the musculocutaneous nerve. Oh, so much information. Here we go. Muscles of the arm. So slide 14, my lord. Muscles of the arm. We have the long head and the lateral head of the triceps brachii, and then we have these compartments, these little grooves that are made up. So the triceps brachii is innervated by the radial nerve, and then we have the long head, the medial head, the lateral head. It inserts at the scapula, the long head, and it's innervated by the axillary nerve. So that one is duly innervated. So it's radial nerve and axillary nerve. That's 2 nerves. That's a terrible 2, but that's what's going to be in there. And I don't know why acroneus is in there because I don't remember talking. Oh, there's the muscle, acroneus right there. Right there, highlighted on the screen. So acroneus is kind of a lower forearm. That's what it looks like to me. And then let's move on to the quadrangular space from much overhead work. So again, lots of overhead work closes up this quadrangular space. What borders that space? The superior inferior margin of the teres minor. So teres minor, teres minor is the superior. The inferior border is the superior margin of the teres minor. I feel like I just said that. The lateral is the surgical neck of the humerus. The surgical neck of the humerus. Kind of not seeing that, so I'm going to highlight that. And then the medial is the lateral margin of the long head of the triceps. The anterior compartment is the subscapularis. Kind of not seeing that either. All right, Hilton's law. It says that any nerve that crosses a joint innervates that joint. So that's a good thing to know. Symptoms often come back during treatment as you're doing work on this quadrangular space, but they get better. And then, as he said, they tell their friends, and then their friends send people to you because you help people get better. And that's a great thing. I think that is about all. Clinical significance. Axillary nerve becomes compressed. The SS of the deltoid results in weakness. Okay. And then triangular space. We talked about the medial triangular space, the borders, the superior teres minor, subscapular. Like, I know at this point, I'm just saying it because it's on the slide. I didn't understand this. So there's a triangular space that's here. It's made up of the teres minor, the teres major, and the lateral long head of the triceps, I believe. And so the superior is teres minor or subscapularis. That's also teres minor. Inferior is the superior aspect of teres major. And the lateral is the medial aspect of the long head of the triceps. The scapular circumflex, it runs through that triangular area. Good. Triangular interval. So I've drawn in the deltoid in blue here. And we want to talk about the triangular interval, the borders of the superior teres major. So I'm looking at the TI right there. And it is innervated by the radial nerve and the deep brachial artery. And its medial is the long head of the triceps, and its lateral is the humerus or lateral head of the triceps. Contents transmitted. The radial nerve goes through there, and the profunda brachii. It will lie in the groove, the radial groove, for the groove. I just kind of jumbled words together here. Look at the slide. And the last slide, the ligaments and structures of the elbow. We have the ulnar collateral ligament, also known as medial, as highlighted there. And sometimes this is called the Tommy John surgery, and it's due to repetitive stress, like throwing things. So a lot of times what they do is they'll harvest the palmaris longus. This is the tendon that some people have in their hand if you touch your thumb to your pinky finger and then flex your wrist forward. There may or may not be a tendon that pops out of the wrist, basically right on the media, right in the middle of the line on the wrist. And they'll use that to repair the ulnar collateral ligament. Now remember, ulnar is pinky side, right? That's the side the ulnar comes up, so it's the medial side. And then we have the radial collateral ligament, often associated with traumatic injury. And then there's the annular ligament, which is the site of injury in children by pulling on the arm. Sometimes as the kid gets their arm pulled, that ligament gets damaged. That's that one. Highlighted. And then the interosseous membrane, which I don't know why we didn't even really talk about that. Boom. That's the end. I am happy to be done.